This was. Oh, good evening, everyone, and welcome to Indian American Forum. Indian American Forum has been instrumental in bringing us awareness on various topics, whether it is social related, whether it is medical, educational related, month over month, year over year. Even during the difficult months of the pandemic, we brought to you a lot of awareness, and this was one forum that everybody had their eyes on and wanted to look up to have the accurate information, not only accurate information, but also informative awareness and truth. That's what Indian American Forum stands for, to bring together the community, to raise all of these awarenesses. And with us today, we have a lot of leading doctors who, of course, are going to talk to us about the month of, the National Colorectal Cancer Awareness Month of March. But these are outstanding doctors in their own fields, and we can look up to them for any guidance, and they are basically your friend by your side. Indian American Forum brings you a variety of programs, whether it is your Women's Awareness and Awards Month, whether it is your Senior Forum Month. There is one program for everybody. And there is also kids programs that we bring to you every year in summer. That's a huge success as well. So every month we have the community getting together, getting all this instrumental information, and of course, we don't forget to have fun. All of this being led by our own leader, our own inspiration, and a powerhouse of woman power and empowerment, and that is none other than Indu Jaiswalji. Indu Auntie, everybody needs no introduction. But there is one thing I want to go ahead and highlight to everyone here, that she's not only a leader, but she's a mother to everybody. And only a mother can think of caring, sharing information, raising the awareness, and also leading us in the right direction. And I don't know when she sleeps, because no matter what part of the day you call, she's always there to help the community. So without any further ado, let me go ahead and turn it over to our favorite Indu Jaiswal so that she can go ahead and talk to us about today's program. Indu Auntie, the floor is all yours.
Namaste. Flora, thank you for those kind words and kind introduction. We want to, on behalf of Indian American Forum, we want to welcome all of you today for joining us in this very unique and special National Colorectal Cancer Awareness Program. I'm a registered dietitian profession myself, and I work in health field. I've been working with doctors, physicians, ever since I started working in this country. So creating awareness of any disease process and prevention and treatment is always our goal. And many times we tend to ignore certain areas, and many times we don't listen to our physicians, and we take things very easy. And when we are told that, okay, you need this, we never make time. Unless you get very, very sick. So Indian American Forum, as Flora had said, we are community-based non-for-profit organization, and we try to help our community create awareness. I'm not going to repeat what Flora has said, but you will. I'm about to thank all of you and all our sponsors for always standing with us, supporting our programs. And today we are also joined with very, really our powerhouse, I would say, brokers of medicine in Long Island, and they agreed to share their expertise and bring their knowledge to our community and to our members. We are extremely grateful and thankful to these physicians who have taken their time out from their busy schedule to be with us. So I hope everybody who is joining today will be able to get some valuable information and will apply in their daily lives, as it will be explained by our very celebrated physicians and our speakers. Before we start, we want to thank our host committee members Jyoti Gupta ji, Flora Parekh, Dr. Bhavani Srinivasan, Anju Sharma ji, Bina Kothari, who always help us in running these Zoom sessions. We want to thank all of them for helping us in initiating this program. So, going back to our main topic, we are going to start with our, since it's a March is National Colorectal Cancer Awareness Month, we want to welcome our own daughter. Actually, I call her Dr. Preeti Mehta. You know, she is so smart. She is so brilliant, and she was one of our honorees a few years ago. She is the recipient of our Women's Achievements Awards Gala Award, and you know, at such a young age, what Dr. Preeti Mehta has shown to the community, what we can do, is really, really remarkable. And Dr. Preeti Mehta is, you know, her parents are very, very well known. Another business, you know, powerhouse family, Mr. and Mrs. Golia. Mr. Golia is here on the call. We want to welcome all of them. And Preeti, they are very proud of you. Preeti
No,
Mehta, I'll just give you a brief information. She's a gastroenterologist and hepatologist. She is colon cancer care and she treats patients from diagnosis to treatment. And you can see the slide. She is the president of the digestive disease care, where Preeti, I have been there, you were not there, but I was. Talk about HIPAA, so let's not talk about that. But you know,
First-hand experience.
on that note, give a round of applause and please welcome our own Dr. Preeti Mehta. Preeti, the floor is yours.
No, thank you so much. Thank you for actually giving me the opportunity. And you've always taken care of me. You've always taken care of me. And I feel so proud that I can do something to do something for the community. And you're absolutely right. You know, March is a colorectal cancer awareness month. And you know, we know that particularly in the Indian community, colorectal cancer awareness and detection and the fear is there. And so I think today is a perfect way to kind of talk about it a little bit. And I'm glad that this is going to be, you know, shown and recorded so that at least if people are not here, they can at least listen and they can have the information. So thank you so much for having me here. And I am going to start out by presenting a little information about colon cancer, and then we'll talk some more. Yes. And if there's any questions, please feel free to stop me, interrupt me. I'd be happy to give any kind of information. So my title, as you can see, is colon cancer. It's from diagnosis to treatment. The first slide really is to kind of tell you about what colon cancer is. What is a colon, right? Colon is basically, it's a large intestine, which is basically the final part of your digestive tract. And if you think about it, colon cancer, it's the most common type of cancer worldwide. And if you look at the World Health Organization and their data, colon cancer is the third most diagnosed cancer globally. And they say that 1 million new cases are being diagnosed every year. So this is a crazy statistic. And same thing if you look at the United States, the colorectal cancer is the third leading cause of cancer-related deaths among both men and women equally. So the importance of today's really lecture is that early detection is extremely important. And it's significant because not only does it increase the chances of successful treatment, but also a very perfectly normal, healthy life thereafter. Now, if you look at this picture, what I'm trying to show is the colon, right? We're talking about colon cancer. So the colon basically is a very important part of our digestive tract. And it basically is about 5 feet long, and it has multiple different sections. It has the descending colon, then you have the transverse colon, then you have the ascending colon. So basically, its main function is to process nutrients for foods, to absorb water and salt, and basically another storage form of kind of keeping the waste and then eliminating thereafter. So today we're talking particularly about this large organ, basically the colon. Now, what we talk about colon cancer, how does it begin, or where does it even start from? This is a little pictorial to show how a small, tiny little cell, which is, we call it in the medical world, it's called a polyp. But in my world, I tell my patients that when I'm doing your colonoscopy, I'm looking for this tiny little pimple, because literally these little cancers, they start out with a tiny little bump in your colon. And over time, as you can see, this little bump starts to become bigger and becomes even larger. And eventually the cells start to change shape and form, and then they lead to cancer. And eventually this cancer, if we don't detect early, can actually go and invade into the other organs, meaning it goes and invades into the blood vessel that I'm shown right here. And then once it goes in the blood vessels, it goes all over and it becomes metastatic. But the whole important point that I want you to understand, and everybody should know, is that this is where the colon cancer begins with. So with our colonoscopy and early detection, we can prevent and cure and treat colon cancer. So basically, another simple way to say is that a polyp is basically a small clump of cells which line the colon. And usually, majority of these polyps that I find when I'm doing a colonoscopy are harmless. They do not become into cancer. But some of the polyps, they do go on and become into adenomas and then eventually become into colorectal cancers. Now, important point to understand is all that not all polyps become into cancer. But the most important point here is that all of the cancers, they start out from the tiny little polyp that I showed you in the picture. So most importantly is that by screening and by doing a colonoscopy, if we find that tiny little polyp, we can remove it right then and there, and we have completely prevented that complete sequence of it leading to cancer. Now, this is what happens when I do a colonoscopy. I find these polyps. Now, you see this polyp it's basically a pedunculated polyp. We call it a little mushroom. So what we do is this little mushroom is never going to cause you any symptoms. But that's what we do when we find and we go in for patients with a screening colonoscopy. And eventually we find this, we remove it, and we're done. We've prevented the sequence of it becoming into colorectal cancer. Another tiny little flat polyp right over here, which basically does not cause any symptoms, doesn't cause any anemia, weight loss, nothing. But imagine over time, if you don't get this procedure done and if you don't detect it, what's going to happen? It's going to become into this stage. It becomes bigger, right? And again, this sequence from here to here to here takes about years. It takes at least, 10 plus years. However, majority of the times you're going to be asymptomatic. And then this is the eventual stage where it actually becomes into cancer. And even till then, sometimes early cancers don't present with any symptoms. So that's why important point again is we need to get our screening done. We need to prevent this thing done to make sure that doesn't happen. Let's look at this another polyp, another weird looking polyp. You see this little dip over here. Again, this is not going to cause you symptoms, but it's there. And this eventually is going to become bigger and becomes into cancer. Same thing, another example. These all examples are to make a point that majority of these polyps are asymptomatic, but the sequence is there. If we don't get screened, we don't find them, they will become into cancers. But again, important thing is to get screened. The next slide, again, more examples just to kind of point out and hone in the point that, again, these patients all came in for a simple screening colonoscopy and asymptomatic. So that's the point that I'm trying to make sure and see how when they came in, this was pretty big, but with our technology, we removed it completely. And guess what? We've prevented colon cancer. Next slide. So this slide basically is again pointing out that, you know what, even this is the only cancer where we can actually detect and cure completely. Let's look at the next slide. Yes. So this is basically what we do is this is a fiber optic scope. And basically it looks like a snake. And we do is we take the scope, and it basically has a light right at the end of the scope. And basically the light sheds, and we go slowly throughout the entire colon, and we're looking at each of the fold, and we're looking for these little growths, and just go all the way to the end of the colon. Now, I'll also tell you that majority of the times we don't find any polyps, and that patient is home free for the next 10 years. So in that view, yes, if you do your screening at the appropriate age and we don't find any polyps or any growths and there's no family history, we're done for the next 10 years. So it's one test which is very, very useful, and it doesn't have to be done every year. It's just that one time. And if there are polyps, we're again helping and finding these early cancers. Once we do find a polyp, you see what our technique is. We actually take, with my scope, this is my scope, I'm taking a little snare like a lasso. I grab the polyp, I close on the polyp, and I remove it, and we're done. So basically that's my purpose of doing a colonoscopy, is to find these little guys, burn them, cut them, and then we eventually send them to the pathologist. They look under the microscope and they give us an idea if this polyp is precancerous or if it has any kind of early cancer. Basically, that dictates when I'm going to bring the patient back for a repeat colonoscopy. The next slide that I'm going to actually also say is that we have to find out what are the risk factors. Who's at risk for colorectal cancer? Now, if you look at this slide, this is very important. The lifetime risk of a colorectal cancer for men is 1 in 23. And the lifetime risk of colorectal cancer for women is 1 in 25. More recently, in the 1990s, we found out that there's a twice as much the risk of colon cancer in patients who are in the 50s, and 4 times more of rectal cancer, those who are born in the 1990s and after, compared to 1950s. So the question becomes, what the heck is going on? Why are patients in the 1990s and getting more and are at more risk for colon cancer and rectal cancer compared to the people around 1950s? What's changed? And why are younger and younger people getting it? We don't know the complexities. However, they do suggest it's an unhealthy diet, sedentary diet, are things that may contribute to these new trends. And more recently, because of this, we've reduced the screening age, which used to be 50. Now it's 45 years of age. So nowadays, we have to start our screening age at the 45, not 50. Let's look at other risk factors that can cause, may prepone you to actually maybe developing cancer earlier. So the most important thing is if there's any family history of colorectal cancer. So if you have a family history of colorectal cancer, mother, father, brother, they ought to get their colonoscopy even earlier, meaning they get to get their colonoscopy at the age of 40. Now, if there are multiple family members, then the whole procedure changes. You have to end up doing genetic studies, and these patients may end up even getting a colonoscopy at the age of 18 to 20 to 25. So most important thing is family history is key, and that predisposes you to an increased risk. People who also have a history of adenomas and cancers. Obviously, we all know cigarette smoking, alcohol puts you at a risk. Nowadays, as I said, obesity has also shown throughout that all of this also causes increase in cancers, all different types of cancers. I'm not so sure what the data is about gallbladder removal, so I'm not so sure. But the next one, physical inactivity, is huge. And nowadays, articles have, there's research and articles which have suggested not only in terms of physical activity and diet playing a significant role in increasing the risk of colon cancer. We just have to be very careful. And I'll tell you a slide that I have, which really helps and is the right way to go to. Patient also in terms of who had previous other cancers like uterine cancer or ovarian cancer, and if it's at an early age, they're at a risk for colon cancer. patients with ulcerative colitis or Crohn's colitis, which is basically, these are autoimmune diseases of the colon. And those patients are also at an increased risk for colorectal cancer. Lastly, in terms of race, ethnicity, they do say that African Americans in general are a little bit at a higher risk of colorectal cancers than normal. Now, the question next becomes, wait, what are my symptoms? What kind of symptoms am I going to have? So most important point here is that most early colorectal cancers produce absolutely no symptoms. So imagine those, that going back to that slide, if you remember the small polyps, which even became bigger, those patients came in with 0 symptoms. So that's why, again, the point of screening is so important. Early detection is key. And obviously, listen, if there are symptoms, if they're worrying symptoms, and which I'll tell you that you should definitely be careful about, is number one, I think you all guys know, right? Blood and stool. If there's any blood and stool which is unusual, you have to call your primary care physician or reach out to a gastroenterologist. The other thing you have to start thinking is if there is any change in bowel habits, meaning if you were all the time, if you are regularly used to go normal and all of a sudden there's constipation, or if you used to be, if there's such a trend in what changed all of a sudden, I'm going every day, but I'm not going anymore. Or even the change in the caliber of your stool. If the shape before it used to be normal, now it's pencil-like, now it's thin, or it's different worm-like, that's another indication because there are changes. I wasn't constipated, now I'm constipated. My shape of my stool has changed. All those are, again, risks or symptoms that you have to start thinking, wait, what happened? And make sure those, you reach out to your primary care physicians. Patients who start having abdominal pain or rectal pain, another indication to come. Another very important point to think about is weight loss. If it's unexpected or unintentional, you have to be very mindful, you have to be careful and make sure you reach out to your primary care. Last but least important thing is this word anemia, right? Whenever you go for your physicals, your physicians always do something called the CBC, which is basically looking at your hemoglobin and your hematocrit. And if they see that your hemoglobin has dropped, or if your hematocrit has dropped, then they'll say, hey, listen, why are you becoming anemic? And in women, there's a fine line because we all, we all go through this monthly menstruation cycle, etc. But if postmenopausal women who are not going through that and then become anemic, that needs to be evaluated right away. Now, obviously, the next question becomes, all right, so now if I don't have symptoms, do I need to be screened? Yes, right? We just talked about that. Screening means simply getting checked, even when you have no symptoms. So that is the key take-home point that I want you to all understand. Next thing is, okay, so how do you screen? What are the tools, what modalities that we have that we can go and get screened for colorectal cancer? So there are 2 types. One is called the first step screening versus the 2-step screening for colorectal. I'm going to talk about each one of them separately. So basically what the first step, meaning 1-step screening, is basically doing a colonoscopy, right? Meaning it just is that first test, you do the colonoscopy, you're going in you're looking at each fold of your colon carefully. You're looking at to see if there are any polyps, and if you find any polyps, you're removing them right away. So that's just 1 step, and you're getting screened. Now, the next step, the other is alternative that people are working and looking, and primary care physicians are telling patients to do. It's a 2-step screening test, meaning the first one is called a FIT test. It's called fecal immunochemical test. All it does, it basically detects any blood in your stool. So basically, you get a little kit at home, you put the stool in there, and then they look if there's any blood in there. And you do it every year. Now, this test is kind of, I don't, even just having a hemorrhoid, and if you had a constipation, you pushed a little bit and the hemorrhoid bled, it will be positive. So it unnecessary puts you at a little bit of that tense, oh, why am I bleeding? But that is there. It basically is looking for blood, and you do it every year, which is not the greatest, because eventually if there is blood and if it was just hemorrhoid, you regardless will end up getting a colonoscopy. So wait, why am I doing those two tests if I'm a healthy, young 45-year-old? Why am I going to go for a FIT test? Why not just go for the Mercedes of the test, which is a colonoscopy, where I get to see directly, we find the polyps, we remove it, and we're done. There's another test, which I'm sure your physicians must have talked to you, and it's called Cologuard. And I'm sure you guys have seen commercials on TV and etc. And what that is, basically, it's again a non-invasive test. And what it does, it's basically looking at all the abnormal DNA that is present if there's colon cancer or if there are big, large polyps. So basically, we're doing this test to see if there's cancer, because we're just looking for the cells of the cancer, which is going to shed in the colon and the stool, and we're looking at their DNA. But then wait, am I going to wait till that becomes into colon cancer? And that's when that DNA is going to become positive? I don't want to wait. I don't want to wait till those cells become positive and then my stool comes with positive for cancer. I want to do my first step test, which is my colon. I'm a young, healthy 45. Why am I going to wait till that colon cancer develops? Or it also says that you can also detect DNA in the precancerous polyps. But those polyps basically have to be very big, right? You think that those tiny little polyps are going to shed DNA and abnormal DNA? Very unlikely. And it misses almost, it missed, I think there was a recent data which basically showed 1 in 12 cancers were missed. And it gives a lot of false positives. So again, it gives a lot of false positive in patients as they get older. And the funny thing is, all my older patients, they get to their physicians are giving them Cologuard. But it's always, most of the times I have so many patients who come to me nervous. Dr. Mehta, my Cologuard is positive. Am I going to have cancer? They can't sleep, severe anxiety. It's a mess. And a lot of them are all false positive. Again, why would I, again, even if you don't have to be 45, you could be 50, 60, 70. And if you're a healthy 70-year-old with not many medical problems and can tolerate anesthesia, I would always recommend to go for the first line and the first step, which is one-step screening procedure, which is a colonoscopy. But of course, these are non-invasive ways. And this test, it's Cologuard, has to be done basically every 3 years, right? So if it's negative, then we do it in 3 years. Now, if it's positive, of course, what's the next step? We have to do a colonoscopy. Now, there are other tests, other ways. There's something called CT colography, which is basically a CAT scan. So what these patients do is they still drink all the prep to clean out their colon, but they get a CAT scan. This is only reserved for our patients who are very sick, who have multiple medical problems. They can't go through anesthesia. And even those patients, it's difficult to do a Cologuard, it's difficult to do all that. So the other way to do it is to just do a CT scan to look for any lesions. But again, if the CT colonography came back positive, you still would have to do a colonoscopy. So that's the other part. And in terms of colon capsule, it's still in the research. We're still working on it. Maybe in 10, 20 years from now, we will have this. Will be just a little pill with cameras, and it's going to go into the colon and it's going to look for these polyps. But even if it does, it's not going to be able to remove that polyp. So what's the point? But again, these tests are reserved for patients who are sick, who can't undergo anesthesia. And so that's where we have to use our judgment when to use these tests. Let's go to the next slide. So obviously with this slide, what the point is that every patient or every person, men or women who are 45 and above, need to get their colonoscopy done. And we keep doing this up until the age of 75. But remember, I said that if there are no polyps and there's no family history, I don't get to see you for 10 years. But if there's a family history of colon cancer, then I have to see you every 5 years. And if there is there are multiple polyps, or if there are big polyps that I've removed, I'm not going to give you 10 years because you're at increased risk. So I'm going to bring you back in about 5 years. And depending if they're multiple, then I bring you in 3 years. So that's the most important thing, is the new age for detection and early screening.
You missed a lot of things.
Okay. Now, the next question is, in terms of, do we want to do colonoscopies beyond the age of 75? A lot of my patients come, they're like, Dr. Mehta, I'm 78. Why do I want to do a colonoscopy? Again, it has to be individualized, right? Now people are living longer and longer, and a lot of my patients are very healthy. They're living much more than in the past. So again, for patients who are 75 and over, you have to individualize it, personalize it, and then kind of do from there. Obviously, we talked about the FIT, the Cologuard, and those tests are there. But we have to be mindful and careful with the pitfall also. Let's go to my next slide in terms of patients. Again, we talked about family history. Obviously, the most important thing is it's the point is that you have to basically say, you have to take control of your health. You have to talk to your healthcare provider. Listen, I need my colonoscopy. I'm 45 and above. I have symptoms. I want to go see a gastroenterologist. Now, obviously, we have a lot of doctors in our practice. Obviously, you can always seek out if there's anything that you guys need. We're always available. Now, important thing is that we need no excuses, right? We cannot miss this. Some of the excuses that I've been getting from a lot of our Indian community, and which is fine. I completely get it. You know, most of my patients, I'm going to show you some examples and some of the things my patients have told. Dr. Mehta, I'm fine. I have no symptoms. I'm completely fine. But remember the slide that we just talked about. Colon polyps and early colon cancer can develop silently without any symptoms, right? Waiting until symptoms occur can really be a disaster. That means that the cancer has become even more advanced, right? So important thing is, just because we feel fine, you can still develop these polyps and cancer silently. The next thing, a lot of my patients come and say, Dr. Mehta, I'm healthy. Why do I need to get screened? I'm healthy. But again, important point is colorectal cancer screening is for healthy people, right? It's not for my unhealthy patients, right? That I'm going to do no matter what. But colorectal cancer screening is for healthy people. So important point again, we find a polyp, we remove it, and we prevent it from becoming into colorectal cancer.
Okay.
Another excuse that I have, a lot of patients say, you know, nobody in my family had colon cancer. You know, all my family is all healthy and they're all well. Again, the data, if you look at this, roughly 5 in 100 people are destined to get colorectal cancer. 5 in 100. And particularly even if there is no family history. 5 in 100. Just a week ago, I had a patient, 30-year-old, large colorectal cancer with no family history whatsoever. So it doesn't spare anybody. The next excuse that I get a lot of time, and again, it's not excuse, it's fear. They say, I have no risk factors. Again, the single biggest modifiable risk factor for colorectal cancer is to be screened. That's it. Obviously, they say only men get colon cancer. No, it's an equal opportunity disease. Women have the same risk as men do. Obviously, important point here, colorectal cancer can be prevented. Not only can we detect it, but we can also prevent it, right? Now, obviously, just few more slides on just, what to expect, when you're going in for your colonoscopy, what's going to happen? The fear is there, obviously, and it makes sense, right? The fear factor is there. Wait, I'm going to be sleeping, and there's going to be somebody putting a tube up my, in my rectum, and God forbid something happens, and I'm going to be sleeping. I'm not going to be awake. What's going to happen? So it's very reasonable for all our patients to worry because it's a scary procedure, true. But talking to the patients, discussing this, making them aware how it, how we can make it comfortable for them. We all know, and I think a lot of you guys probably already had your colonoscopies. Obviously, remember the day before. It's a 2-day thing. 1 day before, you have to be on a clear liquid diet, right? Meaning, we don't want to eat anything solid, because if you're going to eat food, then what am I going to see? I'm going to see poop the next day. So that's where 1 day before you have to be on a liquid diet. And then I'm going to punish you by giving you a laxative to clean out all the old poop that's there, right? So the day before, these are all the different types of clear liquids that you have to drink. You can have coconut water, Gatorade, vitamin water, apple juice. You're not, a lot of my patients also say, Dr. Mehta, I'm going to be so hungry. You're not going to be hungry. You're drinking, you're going to have your chai, you can have your coffee, you can put a little milk if you have to, and you're drinking a lot of fluids. You're just not eating. Again, it's a little tough, but the sugar's there in all your liquids. Now, the biggest fear a lot of my patients say is, Dr. Mehta, to drink all of this nasty medicines. All my friends told me that it tastes really bad and etc. In the past, people used to drink this huge gallon, 1 gallon of medicine. But now with improvements, it's only 2 little bottles, only 6 ounces each. So it's not even compared to what people used to drink. It's 2 bottles, 6 ounces. Yes, it doesn't taste the greatest. I tell my patients to put it in the fridge, make it nice and cold, put a straw through it, and it'll never, ever, you won't ever taste it. It'll go directly to the back of your mouth. So in that respect, the volume has decreased. One step better, now we have pills. So there's no need to worry about taste. So simply, obviously, there are 2 bottles. There are 12 pills in each of them. But, I did my colonoscopy and I did the pill prep. It was easy. I didn't taste it. I had no issues. Drank a lot of water and it was clear and not an issue. So now the fear about drinking the prep should no longer be there, because there's so many different options, even to the point that there's no more taste. We have pills. Obviously, in terms of the day of the procedure, right? Most of, what happens, the nurses take you in, they put an IV, and the most important person at that time is your anesthesiologist, right? Because if you could remember, if you go back to your colonoscopies, you probably all got propofol. Propofol is magic. It's the most safest anesthesia that patients have been getting. And they're sleeping, they're dreaming, they wake up fresh, and the risks are almost minimal. And you have a full flash anesthesiologist watching you. They're watching your heart rate, your breathing, everything. So in that respect, it's a very safe environment. And Department of Health requires all of this, right? So the fear, oh my God, who's this doctor? Who's the anesthesiologist? Now, all our centers, ambulatory surgical centers, we have to report to Department of Health. So more regulations where we make our patient feel comfortable so that they don't have to worry. And within 30 to 40 minutes, I do my exam, another 30 minutes to recover, and you're out of there. And the next day, listen, go back to work, normal routine. There's no issues whatsoever. And nowadays, we're doing all the procedures in our endoscopy center. There's no need to go to the hospital. The hospital you're there longer. The same quality is being done efficiently outside. So in that respect, a lot of our fears are now under better control, because the fear is, I'm not going to eat anything. No, you're eating. You're drinking lots of fluids, lots of liquids, which do have sugar. The laxatives are getting better. The anesthesia is better. And overall, the experience is better. So in those respects, some of those fear factors we're kind of getting rid of. Obviously, with colorectal cancer, of course, once you get diagnosed, so we already know we have 2 of the most esteemed oncologists with us today, Dr. Wasil, Dr. Kalra. It all depends on the stage of the cancer, and depends on that. If it's early detected, listen, surgery and you're done. But again, if we detect it later and it gets bigger and it goes into the blood vessels, then we have to think about chemotherapy and radiation, etc. So that's why it's very important that early detection easier surgery, and you don't have to deal with chemo, radiation, etc. My slide, the last one, a lot of my patients ask is, Dr. Mehta, what can I do? How can I prevent me from getting colorectal cancer? Obviously, listen, there's nothing to, if there is family history, etc., you're at risk. But obviously, diet makes a whole lot of a difference, right? Your diet should be rich in fruits, vegetables, lots of whole grains. Most importantly, I tell all my patients is that the less red meat they eat, the better. Less processed foods, the better. If you think about it, nowadays our life has become so busy. We don't eat breakfast. We just go pick up a bar. We pick up a protein shake and we're on the way. The whole day goes. We don't eat anything. We don't eat properly. So in that respect, the less processed foods we eat, the better it is. That's why our fruits and vegetables are awesome. They're really good. My 3 kids, I have to literally force feed them, but I have to, because I know it's important and they don't like it, but I have to do it. And I think over time, if you train them, they will get to like it. So whole grains, they're very rich in fiber, vitamins, minerals, and have shown to reduce the risk of colon cancer. The next important point is physical activity. We are very busy. We all work. We're in this little cycle and rut. We're running every day morning. You wake up at 5 o'clock, go to the hospital, come back, do procedures, and everybody in their own business does the same thing. But we need to take a breather. We need to exercise as much as we can't and we don't have time, but we have to make time, because exercise is related to not only preventing you from, it maintains a healthy weight, you're also indirectly decreasing the rate, obesity decreases, you're reducing the risk of colon cancer. Smoking, alcohol, we all know that, those are common. But important thing is, remember, eating and physical activity are key to success. And I remember my grandma telling me this, my Baiji, that was her whole thing. Eat properly, 2 minutes baith ke, achhi tarah se kha, fir kuch kar. So that was her saying all the time. So it's true. We're coming back to the same thing. Sit, eat healthy, and exercise. All the things that they used to do, which we don't do because we're always busy and taking care of everybody else. And another point again, what else can we do? Make sure we reach out to our gastroenterologists, reach out to our doctors. Listen, I'm 45. I need my colonoscopy done. I need to get screened. I'm not in a third world country. I'm in America. I'm working so hard. I want to live healthy. So make sure you all go to your primary care physicians, gastroenterologists, reach out to us to help. And so that's really the most important point, is colon cancer is a health concern. We want to make sure that we take care of it. Important statistic is also 30% of Americans are not screened. How crazy is that? That's a crazy number. And in our Indian community, we need to raise awareness. I think we need to bring this out in a bigger forum and make them aware, because the fear factor has to go away. That's the biggest thing. Everybody's fearing that they're going to be in pain and discomfort. No, we have great anesthesia. People are embarrassed. We have females in our practice. We have 5 females and 7 males. There's accessibility. Anxiety over bowel prep, no more. Think about it, right? We are now, forget the gallon people used to drink. Now we have pills. Complication, the rate of complication with the colonoscopy are minimal. Our technology has become so advanced. And I think our doctors are also very conscious, right? The most important thing is we are taught is do no harm. If you can't finish a colon, if you can't do it, stop. Don't push, don't force. So that also is the conscientious doctor. Of course, people worry, oh my God, I'm going to have cancer. Am I going to have cancer? That's the first thing. Dr. Mehta, did you find anything? The fear's there. But of course, now that we are educated, people are aware, it's better. And last but least, listen, we all have insurances, right? Insurances cover preventative things. Screening colonoscopy, you don't have to pay any deductible, nothing. So now insurances are giving letters out to every patient. Listen, go get your screening done, because they know that if they miss that colon cancer, not only will they need surgery, they'll need chemotherapy, the cost will be ridiculous. So that's a brief presentation, and thank you so much. I don't know if I went over time, Please feel free to ask me any questions, etc. Thank you again.
Wow, Dr. Mehta, unbelievable presentation. This is really, really in thorough. You explained in layman's language and the importance of screening and the difference between Cologuard and colonoscopy. So, which, a lot of doctors do tell us. And it's simple, it's like a whole package. You have to, and being a big dietitian myself, the healthy lifestyle,
Yes.
we go side by side. So it's you have really given the true picture of why colonoscopy or prevention is needed. So now, in case we have a diagnosis, I would, first of all, ask our audience to have your questions later on because we have two other speakers. Dr. Wasil is here, otherwise I see Dr. Kalra is there. So, Jyotiji, do you see Dr. Wasil?
I'm here.
Yeah, he's here.
So can we have who wants to go first, Dr. Kalra?
Ladies first.
Oh, very fun.
Jyotiji, can you please invite Dr. Kalra?
Yeah. Before I introduce Dr. Kalra, I want this screen, like sharing
Oh.
screen to be
Yes, I'm going to stop
out
sharing.
so that we can see everyone,
Absolutely. I'm going to stop sharing. Yeah.
Yes.
Is that clear?
Perfect.
Yes.
Perfect. Perfect.
Thank you.
And
Thank you.
let me highlight Dr. Kalra, and here we go. Okay, I'm so happy we are here today, and we heard Dr. Preeti Mehta. Very, very nice session, and we learned so much. Now I want to introduce Dr. Jagmohan Kalra. And Dr. Jagmohan Kalra is a board certified hematologist and oncologist committed to providing the best care to her patients. And she has over 53 years of experience in the medical field. And she graduated from Lady Harding Medical College, University of Delhi in 1970. And she's doing so much for the community. Every other week we do health is wealth with her, and she is not only oncologist, she has knowledge of everything, and lots of people are getting benefit from her. So I am very happy to bring Dr. Jagmohan Kalra, my best friend.
Oh,
Hello, everybody. Thank you, Jyotiji, and thank you, everybody, for coming at this time. I was very impressed with you. Preeti, you have left nothing for us to talk about, but we will talk about certain things. You really stressed on screening so well. If everybody gets screened, there will be no cancer to talk about and give treatment anymore. Really, you did a really home run, I call it. But you said Mercedes. Nowadays, everybody wants Tesla.
I
So,
know. I was going to say Porsche. I was going to say Porsche.
Okay. All right. So let's just highlight some of your, whatever you said. The important thing is we are so afraid of colonoscopy, our community. I see so many patients. Everybody is afraid of, let's say, anesthesia. And what you talked about is the people, what will others say? Oh, she had this test. And the women especially, all Asian, Muslim women, nobody wants. And I'm so glad there are female GI, colonoscopy people, GI, like you, because there are only few. So I know the names, and I said, you don't have to go to a male doctor. That's one of the fear the women have. They don't want to go to the male doctor. So I'm so glad you are there that I can give them the names. They still don't want to do it. But today you even clarified that I could tell them that there are hardly any complications, and the propofol is only for a short time anesthesia, and it's a very self-limiting anesthesia. It's not going to put you in a deep sleep. One point I would like to say is that people should know they should not go alone for colonoscopy. People do know that, but you have to tell them, like I have to tell them ahead of time, because you're going to get anesthesia. So somebody has to drive you there, especially if you haven't eaten or drink for like a whole day. You could pass out dizzy, and somebody has to bring you home. But like you said, they will be fine within few hours. We all went through that. And after what I wanted after 2-3 hours of colonoscopy, my coffee. So you can have that coffee. So the preparation is very hard. It's not easy. I know you put it like this, but it's not that great. But don't be afraid. The benefits are more than side effects. So screening colonoscopy is one thing so important. That's just a take-home message today. If you guys learn, guys and girls, learn nothing. Just have your colonoscopy. Tell your sons, if they're older sons and children, they may think, oh, mom, I don't have a family history. Not true. 45 age. And one of the reasons they changed the age is they found in 2020 statistics, they were people or the male and female both equal. Males are a little bit more prominent than female, were having colon cancer between 0 to 49. Zero. I just saw the statistic, American Cancer Society. Why would you do that? I mean, so even the young kids with their family history, they have Crohn's disease, ulcerative colitis at a young age with all the stresses we have. So colonoscopy is the take-home message today. But I do see patients who become anemic. You very clearly pointed out in the women, they can have iron deficiency anemia. But anytime a man, whatever age it is, has
Yes.
iron deficiency anemia over the age of 45, colonoscopy is a must. And that's the screening colonoscopy.
Right.
But if the age is even 75, if they have iron deficiency anemia, we call it diagnostic colonoscopy. So there's no age for diagnosis. If there are symptoms, pain in abdomen, iron deficiency anemia, hemorrhoid could be very confusing. We think, oh, we all have hemorrhoids. No, that could be fresh rectal bleeding, could be cancer of rectum, not colon. See, rectum is the last part of the long intestine colon. That can happen. We put them together. We call it colorectal cancer. So let me just tell you the statistics. The most common cancer in women is the breast cancer. In men is lung cancer, even though women get lung cancer too. Prostate cancer in men, and the colon cancer between men and women is the third common cancer in this country. And there's mortality. Not everybody lives. So one third of the patient, if there are 150,000 cases of colorectal cancer in this country, 50 to 60,000 dies. That doesn't mean that same group dies. They're living longer, but their statistics are very hard to follow. Every day there will be 1,600 people dying, 1,600, sorry. So that's why we have to be having screening. The screening means this is one of the cancer that can be cured with screening. Cured means cured because you're removing the polyp that becomes cancer, which is really so important. And everybody today, if you haven't had a colonoscopy, you are calling Dr. Mehta. She gave you the phone number. Go for screening colonoscopy. So other symptoms can happen which may be late, like pain in abdomen. But there are some people I've seen sudden onset of pain, never had pain, have no iron deficiency anemia or anything, but they can get an obstruction. That obstruction could be from the previous surgery or whatever the reason is. They could be developing colon cancer slowly. In olden days, my days, we used to say if you see an apple core lesion in the X-ray, it's typical for colon cancer. I've never seen a case like that. Have you heard that? No,
I've heard it.
lesion.
Absolutely, yes, yes.
We
yes.
don't let it happen anymore because we get colonoscopy. Then the other symptoms, very important, is a lot of men and women have diverticulitis. They can have abdominal pain. They can have little blood in their stool. So these could be silent symptoms of colon cancer. So if the colon cancer is not colon cancer, if the polyp is removed, and the other important thing you said, the size of polyp is very important. Number of polyps is very
Preeti
important.
Mehta,
Did somebody say something? Okay. If she can tell us, she had a beautiful, very wonderful slides. The size of polyp, if it's less than 1 centimeter or 0.2 or something, may not need every 3-year colonoscopy. So you don't get scared. There's one small polyp so tiny. Okay, she will say 5 years. She may say 7 years. So don't be scared that everybody has to have every 2 years of colonoscopy. And the size of the polyp, the type of polyp, when the pathology is, see, some patients, but they don't know their pathology. So I have to review the pathology and say, okay, this is serious polyp. You have to go back. Otherwise, they're going to go back to you. I had my colonoscopy. I'm done for 10 years. Not true. Everybody's colonoscopy or everybody's body is different. So these are some of the small things which we do before and after they had colonoscopy. Now let's see. Polyp removed, chances of cancer very small. But what if you have early cancer? Early cancer means stage 1. It's superficial only on the inside of the tube. Colon is a tube. You have 90% survival rate, less than 5 to 10% chances it will spread. So 90%, great, you know. So let's get it diagnosed at 0 stage, which is polyp. Stage 1. Stage 2 is goes deep, a little bit deeper into this tube. Tube is this thick. If it's deeper in the tube, still great chances of cure. But we have to decide as an oncologist, looking at the pathology, that whether it is needs a treatment or no treatment. Stage 2 may need no treatment. Stage 3, most of the time we give treatment. It's called adjuvant chemotherapy. That means the patient may do well, but if we give a chemotherapy to prevent the cells from leaking out of the tube into the rest of the body, like liver, most common, then we can still cure them. Stage 4 means the cancer is gone into outside the tube, into the lymph nodes, still stage 3, or into the liver, into the lung. We are, as an Indian community, never let it going to happen now. Everybody got to have colonoscopy. So even the stage 3, 4, there are so many advances of immunopathology, looking at the pathology in the lab, what kind of new targets are there. It's called targets, not the target store. The target in the cancer is the cells may be developing this different kind of hormones or different kind of cells that we can give therapy against them. It's like giving them a shot, looking at where the person is standing or the target is standing. So many new therapies. And the cancer can be followed with a marker called CEA. CEA is a blood test, not diagnostic. We don't diagnose. But once you have a diagnosis, that gets done before and after, and helps us tell us that cancer is getting better or we need to do more aggressive treatment. And I think I want Dr. Wasil, if you want to talk about a little bit of chemotherapy or, targeted therapy. Otherwise, our take-home message, colonoscopy.
Thank you, Dr. Kalra. Very, very, very well done. So now we are going to be, I see a lot of good questions are coming in the chat box. So Flora, can you just, see whatever questions we have? Dr. Tarun Wasil, he is a medical oncologist and hematologist in the New York Cancer and Blood Specialist in New Hyde Park. He is a clinical assistant professor of medicine at Barbara and Donald Zucker School of Medicine at Hofstra. Dr. Wasil has a tremendous experience in oncology, very well-known oncologist. And Dr. Wasil, we want to thank you for taking your time out and joining us today. So, floor is yours, Dr. Wasil.
I'm just going to make it about 10 points because enough has been said and time is of essence and we have a lot of questions to answer. As Preeti and Dr. Kalra has already outlined most of the stuff, and I work with Dr. Kalra actually. We are in the same group, and prevention is better than treatment. Prevention is better than treatment because we'll go over some of the survival statistics Dr. Kalra already mentioned, that stage 4, only about 5 to 10% of the patients live 5 years. So if we take 100 patients with stage 4, only 5 to 10 of them will live 5 years. If we diagnose at the polyp stage, close to 100 of those patients will live for 5 years. So that's the difference between prevention and treatment. And we basically use National Comprehensive Cancer Network guidelines. And many times I open the National NCCN guidelines in front of the patients to show them where we are coming up. If we try to come off the top of our heads, that may be wrong in some cases because treatments are changing almost every few months for all stages of cancer. So we try to use NCCN guidelines on a daily basis and review them in the tumor boards. Many cases are not straightforward. So we discuss them with surgeons, gastroenterologists. Many times, every time I have a patient with rectal cancer, especially or sigmoid colon cancer, I call Preeti, I call my surgeon to find out, and the pathologist, to find out exactly what was the spot, because rectal cancer is treated a little bit differently. We include radiation therapy in that quite a bit. In colon cancer, we don't use radiation almost never. So that's the difference. So, but we have multidisciplinary tumor boards where we have radiologists, pathologists, gastroenterologists, medical oncologists, radiation oncologists, surgical oncologists. So we discuss all these cases on a regular basis. So not every case is the same. And in order to advance the science of medicine, we prefer clinical trials. And at New York Cancer and Blood Specialists, now we are a group of 100 oncologists all over 5 boroughs and Long Island, and also in upstate New York now. So we have some clinical trials, and we have a major affiliation with Memorial Sloan Kettering Cancer Center. We can refer the patients there with a click of a button, and they can participate in clinical trials if we need to send them there. It's important for us to see the patients as soon as possible. So we try to see the patients sometimes within 2 weeks of surgery. I prefer them at that stage because we have to do some genomic analysis even at early stages of cancer. You'll be hearing a couple of words actually. Genomic analysis, mismatch repair genes. We have to know about those before starting treatment. And the treatment after surgery has to be started within 6 to 8 weeks. And we need 2 to 4 weeks to just get the genomic analysis done. So as soon as the patient is ready to walk, we try to see that patient. I see that sometimes we have a sort of patients don't want to come out because they say, I just had surgery 10 days ago or 2 weeks ago. But it's important for them to come to the medical oncologist's office so that we can evaluate them properly for the proper treatment. In stage 4 cancers, we always do genomic analysis. We look at about 350 different genes to come up with any targets, which Dr. Kalra was mentioning, because there are about 4 or 5 targets in colorectal cancer, which can be specifically targeted or are actionable with certain specific medications, which are not chemotherapy medications typically. And not every stage 4 cancer patient is the same. If there are only 1 or 2 or 3 spots in one area of the liver, or maybe 1 or 2 in the lungs, we can resect them. And those patients can also have a long-term survival. So all stage 4 cancer patients are not the same. Again, talking to your surgical colleagues, talking to your radiation oncology colleagues is very, very important on a regular basis. So we do that. That's why most of the time, actually, even if we see, say, 20 patients in a day, it doesn't mean that our day is very short, because we are just discussing cases back and forth with all the other specialists involved in that case. So adjuvant chemotherapy, Dr. Kalra mentioned, it's for micrometastatic disease, which means there are cancer cells floating in the system, and we try to attack them for a potential cure. So those are some of the messages I can give, and I think we should take questions because hour is late at this point.
Thank you, Dr. Wasil. And also, I see we are joined with Dr. Preeti Mehta from Chicago. Renee, welcome to the program. We'll ask your comments later on. Flora, do you have any questions?
Yes, I do have. I have a couple of questions. First of all, thank you, doctors, for your valuable time here. I will go ahead and I have compiled the roster here. Two very common questions. We addressed a lot of myths here. Like, a very common myth is that if your doctor does not advise you, there is no need for you to have a colonoscopy, which is a completely incorrect statement, because we say there is no age, you're 45, get it done. Also, there is a comment in here for a recommendation on gastroenterologist, and I have to tell people we have two very renowned here on the call. Dr. Preeti Mehta is here, and also I see Dr. Nilesh Mehta, her spouse, has
They're
also.
one and the same.
Sorry?
They're one and the same.
One and the same, yes. So we do have them here, and of course you can look them up also. One question, and this was something that I had in my mind also. There are a lot of diagnostic tools out there, like whether it is some ultra magnifier, some color spray, and also there is rectal cancer diagnosis. There is this colonoscopy. So there are tons of tools out there, and one for each stage. So as a common person, how safe are these diagnostic tools that are available out there for me? And like you addressed a lot of fear factor, but how safe are these tools for me? Because there is another myth out there that these aren't safe, or these are, one thing is always better than the other. So any comments on that?
I will take it first.
Preeti, why
I'm not a
don't you?
gastroenterologist, but I don't want them to think that gastroenterologists will always favor their own tools and stuff. So I think colonoscopy stays the gold standard. You heard about Cologuard, you heard about FITS test. There was a paper just last week in New England Journal of Medicine, which is one of the best medical journals, on blood tests for colorectal cancer. Now, all these tests again detect cancer to some extent, but colonoscopy can prevent cancer from happening. So I think unless the patient has any severe cardiac condition, severe pulmonary condition, severe kidney problems, we don't want those patients to go without colonoscopy. So if the patient has serious comorbidity, then patient may be able to get colonoscopy in the hospital setting. But if it cannot be done for any reason because the risk of the procedure becomes very high, then we go to Cologuard and less sensitive tests, in my opinion. And I prefer colonoscopy on my patients because
We all feel the same. We all feel the same. There are a lot of tests, like you want to hear about virtual colonoscopy. Do you want to hear about FIT test? Stool guaiac it is called, which is still a test being done by the primary doctors when you go for a regular physical. That means they're looking for blood in the stool, but it can only tell you there's something going on, but it's not going to tell you what's going on unless you do colonoscopy. With colonoscopy, it's feasible. You remove the polyp, and the polyp may have early cancer cells. So you have two benefits. You're removing the polyp, which may never become cancer, or you're removing the polyp that has on the tip cells. You have really prevented cancer. So none of us will say other tests are there, but they are the gold standard. Colonoscopy gives you diagnosis. If you have a Cologuard positive, what are you going to do? Colonoscopy? So why not, if it's possible, do colonoscopy and not avoid. Cologuard takes about 4 weeks to get the result. And that 4 the patient is like, oh my God, did you get my test? Did you get? Not yet. You have to mail it to the, patient has to mail it. So it's a test. I'm not saying there's no test. Dr. Wasil said, do it for a patient with a cardiac failure, patient with that. It gives you some sense of, relief. It's negative, but not if colonoscopy is possible.
Also, the risk factor, the risk associated with colonoscopy is very minimal, right? So if you think about, the question becomes like, okay, so what are my risks? What can go wrong with the colonoscopy, right? So that's one thing that I can understand. People say, wait, it's an invasive procedure, and what are my risks of bleeding or infection or perforation? So those are 3 major risk factors with colonoscopy, but they're minimal, 0.1%, meaning 1 in 1,000. So the risk is rare and minimal. So in that respect, if I had to choose the gold standard, if I'm a young, healthy, 45, 55, 65-year-old, and if I have no real major medical problems, why would I not go for the gold standard, right? That's the point. But again, as both our esteemed, oncologists, they say the same thing, right? Listen, FIT test is just checking blood. If you have a hemorrhoid, that FIT test, and if you did it then, it's going to be positive. And you're going to start worrying all the time. You're going to end up rushing to get the call. Instead of you would have done it calmly and quietly, you would go, oh my God, Dr. Mehta, do it tomorrow because I have cancer. They're going to Google my fit test is positive. What is Google going to say? Colon cancer. And the same thing with, Cologuard, lots of false positives. And it only is looking at cancer, the DNA from the cancer cell. So it's not looking at polyps. It's not looking at the small, tiny polyps, which are not going to shed those DNAs and which is not going to be. So what's the point? Why I'm here to kind of prevent.
Problem is the preparation, Preeti, believe it or not, it's not easy.
Yeah.
Preparation is
2 days to 2 weeks worth of discomfort and 10
Yeah.
years free of
yeah. Yeah.
But
The
and
best
more
part-
life to live. That's nothing.
You're
Uh,
absolutely right. The prep is not.
You may not be able to go to a party or two. That's okay.
Yeah.
The other
Then-
thing, my suggestion is that find a very good gastroenterologist or group such as Dr. Mehta's. And there are some gastroenterologists out there who have been working for 30 years or 40 years, but their track record is not that good. And many times they don't even want to touch the patient, even if they have a little bit of a medical issue. And sometimes you see reports of a gastroenterologist saying that, oh, preparation was bad, so come back in 6 months. Some people have almost 30 to 40% patients like that. So that's not a good track record. Once in a while, there's a preparation problem, but it should not be 30 to 40% of your patients who are having that kind of issue. So
I think, Dr. Carla, you made a very good point. The prep is not the greatest. The taste
Yeah.
of the prep, I tell, most of my patients say, Dr. Mehta, this is evil water, and, I tell my patients from the get-go, if you set the boundaries, listen, this prep is going to taste like Jones Beach water with some Robitussin, but as opposed to drinking a gallon, you're only drinking 6 ounces.
Yeah. And just sit in the bathroom that day, take your newspaper or take your cell phone with WhatsApp and Facebook and stay there and no problem. Easy.
But,
Okay,
again,
thank
that's
you.
it.
All right. Jyotiji, do you have any more questions?
There's someone asked a question, like Mr. Shet, he said, I had Cologuard test done with negative result as per PCP. Can we still get colonoscopy? And from your experience, does insurance plan covers colonoscopy?
Absolutely.
Yeah.
Absolutely. You can get a colonoscopy and it would be billed. And like I said, insurance is you just bill it as a screening preventive cancer, colon cancer screening. So it's all covered. So that's one very important insurance. If you guys have insurance and if it's a prevention cancer, colon cancer screening, they will pay for it. There's no need to worry about deductibles and things like that.
I see Dr. Renee Mehra's hand is up. So Renee, would you like to give a question?
Yeah, thank you. First of all, thank you, Indraji, for putting this out together for exponential awareness. I had 2 questions. One was, how effective is Cologuard as a diagnostic tool? And number 2 was, if an individual has a genetic predisposition to cancer in their family, should they, as an early effective measure,
So,
can you hear me? Can you hear me? So should they have the genomic analysis and proteomic analysis?
Are you talking about 2 different questions?
Yes, I'm talking 2 separate
Yeah.
questions. So one was the genetic predispositions to get the genomic and proteomic analysis, and the other was Cologuard.
Cologuard, Dr. Mehta mentioned, has some false positive tests sometimes. So the negative test is very, effective in that way that you can wait for another 2-3 years, but you have to repeat the Cologuard. But if the Cologuard is positive, you need a colonoscopy, and we say that all the time. So it says, okay, maybe I'm okay. But then 2 years later, you will say, oh my God, I have to do it again. And for those 2 years, believe me, you'll be thinking of colon cancer all the time. Why didn't I do this? So if possible, if there is no medical contraindication, if you can tolerate the procedure, which is really not difficult, once they put you in the room, you are out 15 minutes sleeping, you don't even know. So procedure itself is nothing. It's just the preparation is hard, and the thought that I'm having a procedure done to my body is hard. And your second question was genetic predisposition. When you have a genetic predisposition, with multiple cancers in the family, we do have a blood test we call in vitae. And that is helpful, that if it may come positive, then you are going more for awareness of cancer, looking for cancer, breast cancer, ovarian cancer, prostate cancer. So there's a test available for families with multiple cancers. We do the test in our New York Cancer and Blood.
And does the insurance pay for it?
Yeah, it is. If there is a proper family history, I always, send it and it gets paid. Right, Dr. Wasil, gets paid. I've never had
Most
a
of
denial.
the time it does get
Yeah.
paid, and sometimes there is an issue, but the company can work.
Yeah,
We
we do. Yes.
We are
Yeah.
doing so many in vitas these days. About, I guess, 15 years ago, when it was very expensive and insurance companies were not covering most of the cases. But now it's basically every day I order 3 or 4 minimum.
And our insurance companies, on the drug the company, Invita company, genetic company, usually brings some the cost, for the patient who cannot pay. Yeah. They talk.
Thank you.
Laura, do you have any more question?
Yes, Anjuji has a question.
Okay.
Anjuji, you want to go ahead and ask your question?
Anjuji, I sent you a message.
and-
Yeah.
Unmute,
So
Anju.
basically, our question is, if you have done a colonoscopy 9 years back, do you still have to do it again?
Preeti.
You guys, Anjuji, yes, you should get your, so basically, right, if you had a colonoscopy and if you had no polyps in the past and it was all normal, but it was 9 years ago, remember, we do a colonoscopy every 10 years, right? In a healthy, clean prep, no family history, and you didn't have any polyps, then you should do your colonoscopy in 10 years. So basically, you have 1 more year. We'll spare you 1 more. And, the important thing is also we look at the report, whoever did the colonoscopy, and we have to look at the prep, right? Because if they ought to write the prep was pristine and I didn't find any polyps, then I feel comfortable to give you those 10 years. But if the prep wasn't adequate, and if there was a little bit of here, there of the report is not confident, I would bring you earlier. So certainly, yes, you're going to be needing the colonoscopy. Yes.
And also,
Make the point. I want to make the point. If you have colon cancer and the colonoscopy is done for bleeding or symptoms, no, you don't have colon cancer, but you did the colonoscopy for diagnostic purposes, and they may not be able to see the whole colon properly. So you may need a second colonoscopy within 6 months. And if by any chance you have colon cancer, the colonoscopy is needed every 2 years for 2 more times, which is like a rule for patient with colon cancer. So
I think
it all depends.
the other
That's a-
thing is that 10 years is a tentative date sort of time period. But if there's something changed that happens in those 10 years, change in bowel habits, iron deficiency anemia, pain in the abdomen, any sort of weight loss, that means that you need to go for a diagnostic procedure, even if you had colonoscopy 2 to 3 years prior to that.
I think what
Thank
I
you,
think
thank you,
those
Dr.
are my
Wasil.
one
Laura,
quick point that I want to just make, I think Cologuard is big, a question on everybody's minds. And unfortunately, a lot of primary care physicians are giving their patients, young, healthy patients, Cologuard. I'll give you a statistic, first of all, there's 13% false positive rates. That's a big number. And if you think about it, the other part is, right, if you Cologuard is looking for cancer cells. My colonoscopy is actually finding that little polyp and which will never become into cancer. So which one do I want? And the third thing is, if you think about Cologuard, if you look at the big polyps, my colonoscopy detects 95% of them and I remove it. Cologuard only detects 42%. How ridiculous. Why would I send and punish my 45-year-old to go do a test which has all these false positives, all this detection? Why am I going to wait for my young kid or young guy to develop cancer for him to do the Cologuard to get those DNA cells? So honestly, I think we need to educate our primary care physicians more than anything.
Cologuard is not.
Don't, because I've been seeing so many primary care physicians sending 45-year-old.
No, the Cologuard is not approved for 45-year-old.
No, it is 45 and above. 45 and above. But
No,
I think it's the patient driven mainly. Because
yeah,
I have offered Cologuard probably 2 or 3 every week, just because some patients are so resistant,
Yeah,
then you basically negotiate that, okay, you do something. If Cologuard is positive, you will definitely need a colonoscopy. And if it is negative, you will do another Cologuard in 3 years or so. So we do negotiate sometimes because, again, if you look at the data about, I think 56% of the population goes for colonoscopy. Not everyone wants to go for colonoscopy. That's why we are doing these education programs. This is the 5th one this month I'm doing it. And actually myself and Dr. Kalra have been doing breast cancer awareness every October for last 15 years. And last October, we decided that we should do every cancer if possible. And we started in January. We are doing it in Gurdwaras, temples. During longer time, we try to find space. And I encourage everyone to come. Actually, we are doing one on oral cancer in April 7th, I think. And we have done cervical cancer, lung cancer. We have done
Gallbladder.
gallbladder cancer, and colorectal and multiple myeloma is the March month. And this is the 5th program I'm doing. Tomorrow, I'm doing a multiple myeloma for oncologists. That's a separate lecture. So these are we decided that we want to go out to the public and try to make them aware. It's not to scare people. It's to make them aware that these are essentials. And prevention is definitely better than treatment.
Thank you, Dr. Wasil. We are coming towards the end of the program. Any more questions, Flora, or we are done?
No more questions, but there are a lot of compliments. So doctors, thank you so much for your time this evening.
Flora, 1 minute. Can we ask, before we do the vote of thanks, Anjuji, can you just lighten us a little bit with some of your comments? हिंदी में कुछ बोल दीजिए थोड़ा सा, हमारे डॉक्टर्स का शुक्रिया अदा कीजिए।
मैं सबसे पहले तो मैंने जी अपनी डेट चेक की है कि मेरा कब कोलोनोस्कोपी हुई थी, so it was in 2019 December.
So you have time.
So I have time.
Okay.
That's
I'm
very
putting my cell phone number in the chat box.
Okay.
If anyone wants to contact, they can directly contact me. And if they need they are close to Bethpage, Dr. Kalra is there. And if they need to see Dr. Mehta's, just let us know and we will connect you to them.
Can I share my experience?
Sure.
Sure.
Yeah, I had very good experience with the colonoscopy. I have an appointment at 8 o'clock in the morning and I was back home 10 o'clock. It was so simple.
Okay.
So as I said, that not everyone has the same experience. So even if there's some problem, say for 2 days to 2 weeks.
Even I don't come to know when it's done. When
Yeah.
the different room say you're done, you can go back home after 15 minutes.
That's right.
I'm going to share my experience also. My husband also had his colonoscopy done with Dr. Nilesh. And I was smiling when Dr. Preeti, she mentioned about the Jones Beach water, because as soon as he came back home, his first reaction was, he gave me water from his pond in his backyard. I think it was that was his first comment. And it was flawless, and it was not painful at all. All his fear was gone after he had his first one done. So
I want to give some
I have
telephone numbers
mine
so
one done
that
at Northwell Hospital with
Yeah,
Dr.
Jyotiji,
Zimmerman.
you have any comments? Jyotiji, say something.
what I'm
Yes,
saying
yes.
is, because we are going to make a record of this. It will be on YouTube also. So I want to give some telephone numbers. Like if you want to reach Dr. Preeti Mehta, her telephone number is 516-967-4745, and Dr. Nilesh Mehta's number is 646-281-1103. And Dr. Jag Kalra ji, you can also give your telephone number, please.
It's I don't know my office number. You just
And
देखिए
Dr.
जी,
Wasil.
I
आज
don't know
का
my
जो
office number
ये जो
either.
सेशन हुआ है,
very huge group. So you know what? They have
Anji.
like a call number.
Okay,
So
I think Anjuji has something to
हाँ
say.
जी, हम निरोगी रहें, हम स्वस्थ रहें, हम निरोगी रहें, हम स्वस्थ रहें। इंडियन अमेरिकन फोरम हमेशा ही ऐसे प्लेटफॉर्म करता है प्रधान। डॉक्टर जग कालरा, डॉक्टर प्रीति एंड डॉक्टर वासिल, आपका बहुत बहुत आभार, बहुत बहुत आभार।
Thank you.
Tathastu, tathastu.
Health is wealth. Health is
Okay,
wealth.
Flora, we are-
health is wealth, yes.
Health is wealth. Absolutely.
No, it was really very informative session, very informative.
Thank you.
Thank you,
Thank
guys.
you. So Flora, before I say anything, you want to say something?
No, I just wanted to share, Dr. Wasil has also put his number in here. So just for records, it almost sounded like my number. 631-875-3032 is Dr. Wasil's
Fine.
number.
Yeah.
So
So I give out my cell phone number because actually when we are a group of 100 oncologists and all the young people who are not that busy, their slots are all open. So if you call, computer decides where the patient can go. And if you want to see me or Dr.
That's
Kalra,
great.
it's better to
We have
specify.
a general call center, so I can always share my number with you if you want, because it's not a. So I'd rather you guys go through one of this IAF member to get my cell number, so I can give you personal care instead of
Thank you.
coming to my
Thank you.
office.
Thank you, Dr. Kalra.
Yeah.
First of all, we are coming towards the end. A big round of applause and thanks to our panelists, Dr. Preeti Mehta, Dr. Jack Kalra, Dr. Tarun Wasil. Believe me, it's not easy to get 90 minutes from these doctors non-stop. I'm telling you today, we feel so blessed. We feel so thankful that we had such a wonderful, informative session, that you gave us your valuable time. And we are going to share this, session with all our viewers. We're going to make a YouTube, like Jyotiji said, so it becomes a permanent record. So anybody who was not able to join today, it's available online. That is the main goal. Like Dr. Wasil said, we have to reach out to the community. These are the tools that we are using to educate and create awareness in our community. And we will continue to do more, such sessions. We want to thank Jyotiji, our host committee, Anjuji, Flora Parekh, Binaji could not join, Dr. Bhavani was in a meeting, but we have a nice team. We work together very well, and we are able to, put out good programs. We want to, on behalf of the Board of Trustees and the directors of Indian American Forum, we would like to really give you a big thanks and big applause to all of you. And we continue to work, continue to help our community, and continue to take care of our patients and providing them with good health. Health is wealth. I see Dr. Kalra's talk is health is wealth. So that's the number one. And Preeti ji, you couldn't have explained it better. You really you hit a home run today. I'm telling you. Wasil said.
Colonoscopy.
Yeah. And thanks to Jyoti ji ki wo available hoga, if anybody who missed that, they can see that. It
Yes,
was available on Facebook and especially the YouTube.
yes,
It was
will be
already on
available.
Facebook Live,
Yes.
but
Once the
it's
YouTube link is
yeah.
ready, it will be available on the Indian American Forum Facebook page.
Yeah.
It will also be available on the Indian American Forum website. The website is www.indianamericanforum.org. You can see all our past programs there. You can see our slew of pictures there, our videos there, our press conferences over there, our coverages over there. So if you look at the website, there's a lot of information of all the programs. So do look at it.
Thank you, Jyoti ji and Flora ji.
Yeah, I encourage everybody to share on your Facebook page. So like I have so many friends, you have so many friends. I do whatever program Health is Wealth, I put it on my page after Jyoti ji.
I mean, out of these programs, even we can help one person. It will be great thing. So we have to share with everyone.
Now, April 7th, please come to Guru Nanak Darbar if you can, 11:30 to 1:30, and longer will be served.
Yes.
Feel better,
About
Jyoti ji.
oral
Join
cancer.
us.
It's about oral cancer. Oral means any cancer in the mouth. It could be back of the throat, which we don't know. Tongue. I find a lot of Indians with the tongue cancer these days. It could be in the lip. So it's just not that, only few people who chew pan or smoke and drink. Anybody can have. So we have to, supari.
And this is a free scanning on that day?
March is the nutrition month. So, but today, the colorectal.
Yes, that was
March is a colorectal month. April is an oral cancer month.
So we'll do another nutrition month program, because right now we are.
That was Sachin Tendulkar's century.
I
Yeah.
think we really need to have a nutrition month. We
Yeah,
need
we'll
a
do it. We'll do it.
I think every month
extremely
should be, every
important.
day should be a nutrition day.
Because what we eat
Absolutely, yeah.
really makes a big difference, right?
What we eat is what you are.
So we are what we eat.
Yeah, absolutely, absolutely.
All
Oh,
right,
Preeti
thank
ji, I
you.
heard you first time, but you are phenomenal.
Oh,
Really, I
You're
mean.
like a professor, you know, like with
Yeah.
science
हाँ,
and everything.
मुझे अपने कॉलेज के दिन याद आ गए लेक्चर सुनने वाले.
You just nailed it, Preeti.
I mean, I have
Really
seen her.
nailed it.
She is so young, but you know, so like knowledgeable, you know.
Brilliant, brilliant, brilliant doctor.
Yeah, she's very, very wonderful person.
If you need anything,
Kanak
anything,
Golia
I'm here.
ji, yeah, Kanak Golia ji की daughter हैं.
कनक जी आप कुछ बोलिए एंड में. Give us our blessings.
He's always shy.
Who? Who's shy? This group?
कनक जी आते
Oh.
नहीं हैं.
Acha.
He was right there. Would you like to say
I
something?
highlighted him, but then he's gone.
I think he just left. He just left, I think.
Yeah.
Okay, ask Tony. I see Tony there. Tony ji, would you like to say
There.
something?
I don't know what to say. Preeti, thank you so much. She took
I
very
don't
good care of my
know.
mother.
Oh, thank you, thank
Oh,
you.
Thank you,
okay,
Preeti.
great.
And Dr. Vasil, thank you so much for all these programs that you've been performing lately. Seriously.
Tony's
And I'm so fortunate.
daughter is coming to some of these programs for helping us.
Yes. Oh, her, yes, that's right.
Thank you. Yeah.
Radhika.
He's going to become an oncologist, I think.
Under your shadow.
No, if she is interested, sure, why not? We do
God
students.
willing.
Yeah.
Yeah.
Okay.
Thank you so much.
I want to
Thanks
wrap
a
up.
lot.
Thank you.
Okay.
Bye.
Bye-bye, bye-bye. Good
Bye,
night.
everybody.
Bye, everyone.
for
Thank you so
joining.
much. Have a good
Feel
night.
better, Jyoti ji.
Good night.
Good night.
Sir, तेरी